First case, which is very, very commonly asked, it's known as X-linked hypogammaglobulinemia. Are you guys with me?
Yes.
Okay.
Yes.
Okay. Or it has another name known as Bruton's disease. Very, very important. Commonly, they use the Bruton name. They also use the hypogammaglobulinemia. Okay. So, what is this condition? Here, there is abnormality in the B cell. We have T cell, we have B cell, right? Cell mediated immunity and humoral immunity. B cell mainly is responsible for the humoral immunity, and the T cell is responsible for cell mediated immunity. So, in case of X linked hypogammaglobulinemia, what happens is that the child will have some abnormality in the B cell. So, we know that normally in our body, B cell is the one that gets converted into plasma cell, right? And then plasma cell gets converted into immunoglobulin. So what's going to happen is that when the B cell is low, or say B cell is absent, there is some abnormality, there will be no plasma cell. Plasma cells are found in the blood, plasma cells are found in the lymph node, there will be no plasma cell. As a result, there will be no immunoglobulin. That's why the name is X-linked hypogammaglobulinemia. Hypogammaglobulinemia means hypoimmunoglobulin. Almost all the immunoglobulins will be low. All of them. I'm mentioning all of them because there are certain disorders that we are going to study where only say immunoglobulin A will be increased, others will be normal, or M will be decreased, other like that. Okay, but this one, in case of X-linked hypogammaglobulinemia or Bruton's disease, all the immunoglobulins will be low. Now this is X-linked. Okay, X-linked recessive. That means commonly what's happening is that here the males will be affected. So you will always find a family history of a uncle, grandfather having some kind of disease. They will say uncle passed out due to any kind of infection, something or the other. They will give you a positive family history. It's not uncle passed out, or sorry, uncle passed away due to say cardiovascular disease or stroke. No, that's not cardiovascular. This is not hyperlipidemia. This is X-linked. So you have to look into whether you're looking into a family history of infection or not. Okay. Along with that, obviously, the presenting feature in the child. So we have X-linked hypogammaglobulinemia. Remember, it is X-linked. So always, this is very important. There will be a positive family history. All the males will be affected. Uncle, maternal uncle, or sometimes they will say grandfather. Okay. Now, this is the basic. Are we clear till here?
Yes.
Yes, ma'am.
How do they present then? So commonly they present a bit later. What is meant by later? So they present after the age of 4 to 6 months. They do not present very early. The reason is that the maternal immunoglobulin, which is the immunoglobulin that passes from the mother to the baby,
IgG.
G. The IgG, it is actually enough to provide protection to the child up to the first 4 months of age. Okay, plus minus. So 4 to 6 months is the time when, and again this IgM usually starts developing, IgM, from 6 month onwards. So 4 to 6 month of the time is like very sensitive time. Around that time the child will be most vulnerable. So that's why the child will present after the age of 4 months. So we have X-linked hypogammaglobulinemia. They usually present after the age of 4 to 6 months. How do they present? Commonly, they present with cynopulmonary infection. What is meant by cynopulmonary infection? Mainly upper respiratory tract, lower respiratory tract infection. Okay, that means cynopulmonary infection. Meningitis, they can lead to from pneumonia. They can have a lot of things, everything from say an organism. What are the common organism that causes this pulmonary infection in this child? Okay, what are the common organisms? They are Staphylococcus. Okay, something is wrong with my pen. Just give me a moment. Staphylococcus aureus, then we have streptococcus. Give me a moment, guys. So, what cyanopulmonary infection? Then what else? Like only cyanopulmonary infection? No. Commonly,
Skin infection?
usually X-linked hypogammaglobulinemia, it can lead to, but prominently cyanopulmonary. First, I'll show you the organism, okay? Then you'll understand. Staphylococcus aureus. Then we have Streptococcus pneumoniae. Then we have Haemophilus influenza B. Now, Staph aureus, it can lead to skin infection. You're absolutely right. But Staph aureus again can lead to other kind of infection. Also, these children are very susceptible to streptopneumonia as well as Haemophilus influenza. So, Streptococcus pneumoniae, we know it causes pneumonia. It can also lead to meningitis. Haemophilus influenza B causes one condition. What is that? Epiglottitis, right? So not only cyanopulmonary, predominantly it will be cyanopulmonary, but because we have to keep this organism in mind, the child can present with skin infection, can present with pneumonia, can present with meningitis, etc. Okay, so that's why we are saying that mainly they will present with cyanopulmonary infections, but again could be different presentation. Along with that, the children will also have hepatosplenomegaly. So whenever they are sick, okay, and whenever they have this cyanopulmonary infection, say they develop meningitis. Usually meningitis is not associated with hepatosplenomegaly, or say pneumonia is not associated with hepatosplenomegaly. But if this child have X-linked hypogammaglobulinemia or Bruton's disease, they can also develop hepatosplenomegaly. Okay, so remember the organisms. When you remember organisms, it will be easy for you to remember the conditions. Okay, next. Now, how will you investigate? On investigation, you're going to see that all the immunoglobulins are going to be low. All immunoglobulins will be low. Not specified as this. No, all immunoglobulin is low because see here, the B cell is low. So plasma cell will be low. As a result, immunoglobulins will be low. So what is the treatment you think you should be giving? First is when child is presenting to you with any kind of infection, say meningitis. So what do you think? Should I give just immunoglobulin, IVIG? No, I have to first treat the cause. So aggressive treatment of the cause with antibiotics. Child has come to you and you know this child is immunodeficient, so start with the antibiotics. That's why treatment will be treatment of the current infection with antibiotics. Along with that, you are going to give IVIG, intravenous immunoglobulin. Okay, this is the main treatment. Now, along with this, there are other organisms mentioned in the patient info and NICE guidelines. Okay, they are mentioned as mycoplasma. Then, along with hepatosplenomegaly, it is mentioned about arthalgia, etc., etc. For this level, for AKP, I would not suggest you to keep like a lot of information in your mind. That's why I'm sticking to only the book, because we need to pass the exam. If we look into a lot of information, it's going to be difficult. Okay, so just remember here, X-linked hypogammaglobulinemia or Bruton's disease, it is caused due to B cell deficiency. As a result, there will be decrease in immunoglobulins, all immunoglobulins. Okay, commonly presents after the age of 4 months with cyanopulmonary infections. Along with that, maybe skin infection, maybe meningitis, maybe respiratory tract, upper and lower. Plus, the child can also present with hepatosplenomegaly during the infection period. On investigation, you will see that all the immunoglobulins are low. Plus, on treatment, what is the treatment you will give? At first, you will treat the infection with antibiotic, aggressive treatment, and then IVIG. Is this clear? So, X-linked hypogammaglobulinemia or Bruton's disease. Clear with this?
Yes.
I think this is in the recalls also, this is one of the first question. Okay. Next, we are going to study about IgA deficiency. Okay. Now that was hypogammaglobulinemia. That was like all the globulins are low. This is only IgA low. But how much low? IgA is lower than 5 milligram per deciliter. In this case, in case of IgA deficiency, you have to remember very, very important thing. Okay. IgA deficiency will only occur if the IgA is less than 5 milligram per deciliter. In this case, the B and T cell functions are absolutely normal. That means all the other immunoglobulins will be normal. But another important thing, I think we have studied this in FOP tasks as well, IgA deficiency is very commonly associated with all the autoimmune disorders. Okay, so remember IgA is associated with autoimmune disorder. Which autoimmune disorder? Celiac disease, juvenile idiopathic arthritis, SLE. These are commonly associated with, and pernicious anemia as well. They are commonly associated with these autoimmune diseases. That means if a child has celiac disease, there are higher chance that child can also develop IgA deficiency, or maybe the child will have IgA. Okay, so we have to screen for it. That's why in case of celiac, we do a total IgA plus anti-tissue transglutaminase. Okay, till now? Okay. Now, how do they commonly present to us? What are the clinical features? Okay. First, you study what is the cause. Pathology. The pathology is here. The pathology is due to deficiency in IgA less than 5 milligram. Then you can study the association before or after, not an issue. Then you study what are the clinical features. Like in order, set up the order in your mind. Okay. Clinical features. These children, they are saying sometimes they can be asymptomatic, but again, they can present with very commonly with sinopulmonary infection. When I say sinopulmonary, that means again upper respiratory tract, lower respiratory tract infection. Okay. They are also what are upper respiratory tract, and commonly one important condition, otitis media, very commonly associated with otitis media, associated with pneumonia. Okay. And also IgA deficiency is very commonly associated with food allergies. Okay. Plus, they can also lead to some gastrointestinal infections caused by Giardia. So normally Giardia, normal people or say normal children are not very much susceptible to Giardia infection, Giardiasis. But children who have immunodeficiency, they are very susceptible to Giardia. So in case of IgA deficiency, always if child is coming to you with chronic diarrhea, you have to screen for Giardia. Okay, so they come with sinopulmonary infections such as otitis media, pneumonia, along with that commonly associated with food allergies and also GIT infection by Giardia. Okay, is this clear till now?
Yes.
Because I'm going to say something very interesting. So on investigations, what you're going to find is that the immunoglobulin A will be low. Now, what is your normal logic telling you? That immunoglobulin A is low, so I have to give IV immunoglobulin. No, you cannot give. It is absolutely contraindicated to give IgA in any form to this child with IgA deficiency. If he had all the immunoglobulin deficiency, just like hypogammaglobulinemia, all right, you can give it. But if the child specifically have IgA deficiency, then you cannot go with IVIG. You cannot go with immunoglobulin A in any form. Okay. The reason is when you give immunoglobulin A to the child, they may develop sensitization. That is, they may develop another antibody against any kind of immunoglobulin that you're providing. That will lead to further destructions in the body. Okay, further autoimmune procedure. That is why immunoglobulin A, for this immunoglobulin A deficiency, we do not give isolated immunoglobulin in any form. We will only treat the infection with antibiotic. Okay, that is the treatment. As well as if this child, say this child met an accident and he needs a lot of blood, you have to make sure the blood that you're giving is also IgA deficient. That means that person should also not have any IgA, because IgA in any form, whether you're giving in the form of medication, IVIG, whether you're giving through blood transfusion, That can lead to sensitization, and that can ultimately flare up the procedure. Okay, so we do not give IgA in any form. Is this clear? Treatment, we will just treat with antibiotic. Okay, this they have not asked in exam yet, but just remember IgA should not be given. Okay, we have covered two. Now let's go to the third one. I'm just trying to cover the most important ones. The third one is known as hyper IgE. So up to now we have studied hypogammaglobulinemia or hypo IgA, that is IgA deficiency, and now we are studying the hyper condition, hyper IgE syndrome, or known as Jobs syndrome. And instead of using this hyper IgE, hypogamma, commonly in exam, they like using the other term, that is Job syndrome. For hypogamma, they'll say Bruton's. Okay, because if they say hyper IgE, in your mind you can easily calculate, okay, IgE will be high, that means allergic reaction, that means IgE is high, so parasitic infections, along with that skin infections. Okay, like that you can correlate. They don't want that, they want to make it a bit difficult, right? That's the whole purpose of exam. So commonly they give this one, Job syndrome, hyper IgE associated with Job syndrome. Now there is something very interesting here. This is autosomal dominantly inherited. Okay, along with that, in hyper IgE, it is not hypo, so there is no problem with the immunoglobulin. The problem is that it is a combined B and T cell abnormality. So there is abnormality in B as well as T. We are not saying deficiency, we are saying abnormality, some kind of abnormality in B and T cell, that is the cause. So due to this abnormality, on investigation, we will find increased immunoglobulin E. Along with that, increased eosinophils. Okay, this will be the finding. Now, what are the clinical features? Normally, all the immunodeficiency, whatever we have studied till now, they do not have any specific dysmorphic features. But hyper IgE does have specific feature. Let me show you. First, read this, what's written. Asymmetric facial appearance with prominent forehead, chin, deep-seated eyes or deep-set eyes, broad nose and thickened facial skin, or you can say coarse facial features, and high arched palate. Okay, now this you have read it. Now I'll show you the picture. Just match with the picture. Can you see? Prominent forehead, deep-set eyes, like eyes are going inwards, broad nose, thick facial skin, coarse facial features. Thick facial skin means coarse. Okay, so among most of the immunodeficiency that we are studying, Job syndrome is the one which commonly presents with the dysmorphic facial features. Okay, clear till here?
Yes.
Okay, this is very, very important. Okay, so first thing is that what is the clinical feature? The clinical feature is that the child will have dysmorphic facial features. Okay. Second one, because it is IgE mediated, so usually it will cause recurrent skin infections. So there will be recurrent skin infection. Along with that, they can also lead to abscess, but superficial abscess, not deep-seated abscess. Okay, they can also lead to dermatitis, any kind of infection, maybe eczema, severe eczema. Along with that, they can also lead to sinopulmonary infection. Sinopulmonary is common in almost all the conditions. That is static. You just add on different things. Okay, sinopulmonary is like common in almost all the conditions. So there will be some dysmorphic facial features, recurrent skin infection, abscess, but mostly superficial abscess, not deep-seated, dermatitis, and sinopulmonary infections. What do you do for this? Again, you treat with the antibiotic. There is no particular treatment, you will treat with antibiotic. Okay, this is about hyper IgE or Job syndrome. Please keep in mind this is extremely important for exam, especially the fact that it has dysmorphic facial features, because none of the others apart from digeorge have. Digeorge is also associated with immunodeficiency because there is thymic aplasia in digeorge. So thymus is the place where B and T cell get matured. Okay, so when thymus is absent, B and T cell will not get matured, especially the T cell. So as a result, the child will present with recurrent infections in case of digeorge syndrome. That has dysmorphic features. So D for digeorge, D for dysmorphic features. However, none of the others have dysmorphic features till now, except for Job syndrome. Okay. Okay. Now let's move to the next disorder. It is known as severe combined immunodeficiency disorder, or we call it SCID. Okay. So severe combined means what they are saying you severe, and it is combined immunodeficiency, B cell, T cell, complement, everything deficiency. Okay, that means if it is very severe, should this present early or should this present later in life? It's going to present very early, right? Because it is severe. Okay, it's severe. Along with that, also remember this can be three things. Sometimes it can be X-linked, sometimes it can be autosomal dominant, some variants are also autosomal recessive. Okay, but the inheritance pattern here is not very important. Okay, I'm just telling you it can have multiple inheritance pattern. What happens in SCID? So what is the cause? Why there is severe combined immunodeficiency? The problem is that the bone marrow has hematopoietic stem cell, right? Which is supposed to differentiate into B and T cells. And this B cell ultimately differentiate into plasma cells, immunoglobulin, which are the antibodies. T cell activates this procedure, that is plasma cell. Also T cell will activate the killer T cell, the memory T cell, etc. What happens in this particular disease, kid, is that the hematopoietic stem cell or the bone marrow fails to differentiate the B and T cells. That is, they fail to produce or fail to differentiate into B and T cell. So can you imagine B and T cells are extremely important if you follow the immunology, like the basic immunology. Whenever an antigen enters in our body, what happens? It is picked up by the antigen presenting cell. Then it will present it to the helper T cell. The helper T cell is going to again activate the cytotoxic T cell. At the same time, it will also activate the B cell. B cell is going to now produce antibodies against it. And cytotoxic T cell, on one hand, it's going to kill it. On the other hand, with the help of helper T cell, it's going to produce memory cells. So such important mechanism will all be absent in this child because they don't have B and T cells. Okay. So that means there will be no defense in the body. So they'll present very severely. They say that they present around the age of, or say, less than 3 months, less than 3 to 4 months. Okay, they present a lot early, very early. How do they present to you? Mother will say that child is not growing well. Along with that, something or the other, either upper respiratory tract infection, either lower respiratory tract infection, either gastrointestinal infection, either skin infection. Every time something or the other is going on. So first thing is that mother is going to tell you there is failure to thrive, poor growth or growth failure. Along with that, respiratory infections are very, very common. Okay, all kind of respiratory, upper, lower, plus opportunistic infection. What is opportunistic infection? That means these organisms or the opportunistic organism, commonly in a healthy individual, they do not infect the healthy individual. Okay, but if someone has immunodeficiency, someone is immunocompromised, then they become opportunistic. That is, they take the opportunity and they go and infect that particular person. So this opportunistic infection occur very commonly in these children. What are these opportunistic infection? Okay, who are these? Common organism name. This is very important. Pneumocystis girovesi. Before it was called as pneumocystic carini. Now we don't call it. We call it pneumocystis girovesi. And they will ask this name of the organism very, very frequently. Okay, In immunodeficient child is having pneumonia or any other meningitis, any other condition, you have to keep the possibility that this is probably the organism. And accordingly, you have to treat the child. You cannot treat with the normal antibiotics. Maybe you have to increase the antibiotics or maybe go to the second generation, third generation. Okay. So we see there is failure to thrive, there is respiratory infection, there is opportunistic infection by pneumocystic. So what other opportunistic infection? It can lead to GIT infection by Giardia. Giardia, as I told you, very common in immunodeficient child. It can lead to infection by cytomegalovirus. Okay, it can cause infection, candidiasis, that is fungal infection, especially cutaneous candidiasis, usually oral candidiasis, or say in females vaginal candidiasis is common. You don't have to be immunodeficient, you can develop. But if a child less than 6 months of age is developing oral candidiasis or developing cutaneous candidiasis, that is on the skin infection of the skin, that shows absolute T cell deficiency. And it's an alarming factor. Immediately you have to think that a child is developing fungal infection, means it's not good. It's really not good. There is definitely some kind of T cell involvement, T cell deficiency. So cutaneous candidiasis. Okay. Along with that, there are some other, for example, varicella, very commonly associated with varicella infection. Guys, please excuse the background noise. Okay. Is this clear? So there will be failure to thrive. They present very early in life, in less than 3 to 4 months. There is failure to thrive. There is respiratory infections, upper, lower respiratory infections. There is opportunistic infection by pneumocystic girovisi. Plus, there can be other infections like GIT infections with Giardia, G for GIT, G for Giardia, cytomegalovirus infection. The CMV is not very common in normal like children unless they are neonates. There is a torch infection. Okay, unless that, usually CMV is not very common. But these children will have very high susceptibility to CMV. Along with that, candidiasis. This is the most important one they frequently keep asking in exam. Okay, then we have varicella. Again, varicella is also not very common, right? In case of, say, only if there is exposure. Sometimes when we are exposed also, not necessarily we will get the disease, but these children usually they have a lot of, like, with a little bit of exposure also they are going to develop disease. Let's just give me a moment. Yeah. Okay, I didn't want the background noise. Okay, am I audible, guys?
Yes.
Yes, doctor.
Okay, great. All right. So usually this is very important. In case of SCID, the child presents very early, and cutaneous candidiasis is again not something that usually children present with. So when they are presenting with cutaneous candidiasis, immediately you have to consider that. Also, if a child has all this condition, they're having varicella, they're having CMV and all that, we would expect that maybe they will develop hepatosplenomegaly, they will at least develop lymphadenopathy, right? Because lymphadenopathy is very commonly associated with infections. But what happens in this child is that they usually have no lymphoid tissue. This is important. They have no lymphoid tissue. As a result, no matter how sick they are, they will not have any lymphadenopathy. They will not have any hepatosplenomegaly. So it's not like the child is very well. Okay, it's not that the child is very well, that's why there is no lymphadenopathy. But thing is that they do not have lymphoid tissue. So from where are you going to get the adenopathy? So there will be no lymphadenopathy, no hepatosplenomegaly. In fact, on investigations, what you're going to find is that you may find lymphopenia. All the lymphocytes are going to be low. Along with that, because it is B cell deficiency, so all the immunoglobulins will be low. Because it is T cell deficiency, the CD4 cells will be low. Which immunoglobulin? Particularly immunoglobulin GAM. You can just remember like that. Okay. So Did we get an idea about SCID? Usually present severe combined immunodeficiency, so will present very, very early in life, in the first 3 months of life, at max 4 months. Okay. In this case, they do not have any immunoglobulin even from the mother. That does not help because they have severe and combined immunodeficiency. There is no B, no T cell. So only the mother's immunoglobulin here does not help much.